Welcome. My name is Allison Kanzora. I am the project coordinator for collaborative care at Virginia Mason Franciscan Health, and I'll be sharing with you how Virginia Mason Franciscan Health, together with Valley City's Behavioral Health, collaborated to bring behavioral health care into the primary setting. What does it take to provide better, more integrated care for a defined population within our communities? This is a cornerstone question the Innovation Fund sought to answer. Let's take a look at what the Innovation Fund is, how Virginia Mason Franciscan Health put it into practice, and how we were able to answer this very important question. The Innovation Fund is an investment strategy that was offered by HealthierHere. It provided the opportunity for a behavioral health organization and primary care practice to partner in providing care to communities in need. HealthierHere developed and recommended the scope of the work, the investment budget, and asked to explore the types of funding strategies in a value-based payment environment that could sustain the work. The accountable community for health for King County is HealthierHere. HealthierHere sponsored the Innovation Fund and provided the opportunity for Virginia Mason Franciscan Health to partner with Valley City's Behavioral Health to provide care to the community with a collaborative model. In 1920, an introduction to the project was made. Organizations were encouraged to evaluate their capacities and capabilities to participate and identify an organization to partner with. Virginia Mason Franciscan Health and Valley City's Behavioral Health contracted to partner and deliver this care opportunity. The project began in June of 2020, with patient care beginning in early 2021. Virginia Mason Franciscan Health applied to participate in the Innovation Fund, identifying Valley City's Behavioral Health as a community organization to partner with. HealthierHere presented the purpose, objectives, and overview of the Innovation Fund. Organizations that were interested in participating in the Innovation Fund project were behavioral health and primary care providers who have experience working together and have an overlap in the Apple Health Medicaid population. Together, the partners were to design and test an integrated care delivery model that supports the whole health of Medicaid beneficiaries with co-occurring physical and behavioral health needs, as well as explore ways to adapt successful approaches in effort to achieve greater coordination, improving outcomes and patient experience. In addition to seeking patients that utilize one or both organizations, defined focus populations were identified for this project. I will share those with you shortly. Additionally, the partners would create a model that is scalable to other organizations with the intention of sharing the experience. Development of workflows, agreements, and communication standards that will work best to improve integrated care across agencies were specific and significant aspects of this project. These objectives provided guidance in the planning of the project, following quarterly programmatic goals as outlined by HealthierHere, as well as the direction to follow the timeline presented by HealthierHere. The total duration of the project was to be 2 years, with the possibility to continue the project and model of care if it were successful. Using the successful Burien Clinic as a model, as well as support from University of Washington, Ames Center, and HealthierHere, the proposal was made to expand behavioral health services to the Des Moines Clinic. Within Virginia Mason Franciscan Health, benchmarks and metrics are measured for provider, clinic, and region. In terms of consideration of which clinic was appropriate for the project, the clinic's total number of patients, the percentage of patients receiving Medicaid and Medicare services, scores indicating the utilization of the PHQ-9 and GAD-7 screening tools, overall QI scores, and importantly, the interest of the clinic to offer these services. Some of the scores evaluated were from Virginia Mason Franciscan Health's internal scorecard. Such measurements as A1C measurement, A1C greater than 8, statin use in diabetic patients, and diabetic neuropathy screening scores were also considered. Having this kind of data provided solid evidence of which clinic was the best choice to implement the Innovation Fund, as well as the capabilities of Virginia Mason Franciscan Health to provide effective health care to support behavioral health treatment. After discussion among stakeholders, the proposal was accepted by HealthierHere and Valley Cities. As mentioned, HealthierHere presented 4 focus populations for consideration in this project. The Innovation Fund was to serve focus populations with patients experiencing one or more of the following, as seen here. The focus populations selected were patients experiencing mood disorder, depression, bipolar disorder, and diabetes and/or cardiovascular disease. Patients experiencing anxiety were also added to the population. Population data for the selected clinic was captured utilizing existing available reports to identify the number of patients seeking care, with a combination of these diagnoses in addition to the already available quality data. HealthierHere sponsored the Innovation Fund testing models for integrated care and the partnership with Valley Cities Behavioral Health. The partnership was supported by the University of Washington Ames Center, with a project survey completed by Public Health for Seattle and King County. As a sponsor of the program, HealthierHere was involved in working with Virginia Mason Franciscan Health to direct the timeline, milestones, and programmatic goals. VMFH has worked closely with HealthierHere throughout the Medicaid Transformation Project, and a strong working relationship has been established. HealthierHere directed quarterly status meetings to evaluate the work that had been completed, the work that was in process, or work that was upcoming during each quarter. The University of Washington Ames Center also provided oversight on this project. Virginia Mason Franciscan Health has worked very closely with the Ames Center going back to the inception of collaborative care at Virginia Mason Franciscan Health. In relation to this project, an Ames Center representative also participated in the quarterly meetings, asking questions, providing feedback, and assistance as needed. Valley Cities Behavioral Health Care is a nonprofit community behavioral health organization serving King County. Virginia Mason Franciscan Health has collaborated with Valley Cities previously with their co-locating a psychiatric nurse practitioner at a VMFH primary care clinic. That collaboration has demonstrated a strong and mutually beneficial relationship that spoke to the ability of the two organizations collaborating further. Additionally, VMFH chose to present the Innovation Fund opportunity to Valley Cities as they provide services in proximity to the clinic identified for this project. Their leadership was in agreement that the project would be of great benefit to the community they serve. Public Health for Seattle and King County was identified by HealthierHere to assess a portfolio of the Innovation Fund with quarterly surveys that provided insight into the implementation of the Innovation Fund, barriers and successes and sustainability. We had some great wins from the start. As I mentioned, Virginia Mason Franciscan Health had a successful existing relationship with Valley Cities Behavioral Health. This gave the project a head start in terms of having a foundation on which to continue to build the availability of behavioral health services. Use of data captured as well as continued refining of data capture and reporting capabilities supported the proposal and continues to do so. Having providers and clinic staff that are motivated and supportive of implementing behavioral health services was evident from the time of the proposal to the clinic, as well as a steady influx of referrals for services. Our leadership team and champions were supportive for the entire process and were able to provide reassurance and encouragement as needed. VMFH is fortunate to have a behavioral health specialist that has been involved with collaborative care from its very start. The behavioral health specialist was and continues to be an invaluable resource in providing training and support to incoming behavioral health specialists and clinic providers. Along with a psychiatric consultant, they were able to present collaborative care and its practical workings and delivered reassurance to the providers and the staff at the Des Moines Clinic. As always, both HealthierHere and the UW Ames Center were available for any necessary support and direction. Enough cannot be said about the importance of having at least one point of contact for each organization that participate in an open and transparent communication. One of the most important components of successful start was a strong communication between Valley Cities and Virginia Mason Franciscan Health. Effective communication was identified as a foundation for this collaboration. It was especially important as the initiation of the building of this project was occurring during the height of the COVID-19 pandemic. The representative for Valley Cities that served as point of contact was an amazing ally and partner from start to finish. Communication between the organizations was vital. Valley City's representative participated in the quarterly meetings as well as check-ins and updates with the Collaborative Care Program Coordinator at Virginia Mason throughout the project. Working with Valley Cities has been an absolute pleasure. A little history about Virginia Mason Franciscan Health. Virginia Mason Franciscan Health is a healthcare organization serving King, Pierce, and Kitsap counties, and is a result of two of the top healthcare organizations in the region coming together to continue their legacy of care. The two organizations are CHI Franciscan and Virginia Mason. CHI Franciscan's journey began in 1891 when the Sisters of St. Francis of Philadelphia founded St. Joseph Hospital, now St. Joseph Medical Center in Tacoma, Tacoma's first Catholic hospital with 60 beds. Maintaining the founding principles and mission, CHI Franciscan has gone on to open 6 more hospitals, numerous primary, prompt care, and state-of-the-art specialty sites in 3 counties in the Puget Sound. Additionally, in 2019, through the alignment of Catholic Health Initiatives and Dignity Health, became Common Spirit Health, one of the largest nonprofit health systems in the United States. Virginia Mason Hospital opened in 1920 with 6 doctor offices. They went on to be pioneers in healthcare. Additionally, Virginia Mason founded research facilities that have attracted many talented researchers. In 2008, the Virginia Mason Institute was established to provide education and training in the Virginia Mason production system. Finally, in 2021, CHI Franciscan and Virginia Mason finalized an agreement to form Virginia Mason Franciscan Health. VMFH will continue to provide patient care to all in the King County, Pierce, and Kitsap regions, and Yakima County. Virginia Mason Franciscan Health is determined to continue to provide high-quality, patient-centered care. Let's take a look at collaborative care. The collaborative care model was developed by the University of Washington Ames Center. VMFH has worked with the Ames Center since 2016 when collaborative care was launched at the Burien Clinic. There are 5 core principles of collaborative care: patient-centered team care, population-based care, measurement-based, treatment to target, evidence-based care, and accountable care. The links provided here will direct you to the University of Washington Ames Center website. Further links for principles of collaborative care and collaborative care's principles and components. The website is an excellent resource. There you can find in-depth information about collaborative care and useful links for further information and tools. Here you can see a visual representation of the collaborative care model. The model for mental health care in the primary care setting previously would include the patient and their primary care provider only. However, incorporating 2 more essential team members, the behavioral health specialist and psychiatric consultant that have the knowledge and skills to fulfill those roles and to participate in providing care in a collaborative, patient-focused, and holistic way, fills out this model nicely. Utilizing this model allows the patient to receive care in a familiar environment, participating as a member of their own healthcare team to address and treat their needs, physical and mental. With a behavioral health specialist and psychiatric consultant providing support, a patient and their PCP can address further healthcare needs such as diabetes, cardiovascular disease, respiratory disease, and other comorbidities. Here's some more links with further information and instruction about the collaborative care model team structure. Collaborative care is not new to Virginia Mason Franciscan Health. Prior to becoming VMFH, CHI Franciscan introduced collaborative care in the Burien primary care practice. In 2016, with support from HealthierHere in the UW-Ames Center and as part of the Medicaid Transformation Project, VMFH, formerly CHI Franciscan, built and implemented behavioral health services utilizing the collaborative care model. It was introduced at the Burien Primary Care Clinic, the St. Joseph Primary Care Clinic, and co-located a psychiatric nurse practitioner at the Enumclaw Clinic. The pilot programs were able to provide behavioral health care in an identified community of need. The model was built with a strong foundation from outside stakeholders, HealthierHere, UW-Ames Center, and Valley Cities, as well as internal stakeholders that believed that this new way of providing behavioral health services was vital. At the Burien Clinic, the program functioned with a psychologist and an LICSW serving as the behavioral health specialists, one psychiatric consultant, and one designated medical assistant. The behavioral health specialist provided one-to-one behavioral health treatment with the patient, communicated with both the PCP for management of medication and other medical needs, and the psychiatric consultant for medication recommendations. VMA was utilized to assist with data collection and entry of the PHQ and GAD-7 scores to the medical record, as well as maintained a spreadsheet that was initially used as a caseload tracker. She was a point of contact for patients between appointments with the primary care provider and behavioral health specialist. At St. Joseph's, there was one psychologist serving as the behavioral health specialist and one MA to serve in support to both the behavioral health specialist and the patients. Psychiatric consultant was also in the care team. In 2019, collaborative care was expanded to the clinic at St. Francis. In 2020, a new LICSW was hired for the Burien Clinic, and the psychologist that was previously there transferred to the Bonnie Lake Clinic. 2019 obviously brought a variety of challenges in providing care. However, it provided new options for patients. During the height of COVID-19, the clinicians managed to care for their patients at about 50% in person, 50% virtual. As restrictions have lessened and people are returning to in-person health care overall, virtual care remains an option. Patients are continuing to use virtual care at a rate of about 40%, with 60% resuming or beginning care with in-person care. As of 2022, 2 clinics in Pierce County and 1 clinic in Kitsap County are now providing behavioral health services utilizing the collaborative care model. Let's take a look at workflow. As with any new program, workflows need to be developed. The workflow for the collaborative care management program was well honed and is now hardwired into clinics when collaborative care is implemented. It looks like this. When a patient is seen by their PCP for annual wellness visits and/or visits to address mental health concerns, PHQ-9 and GAD-7 screenings are completed. Scores of 10 or higher and/or clinician's judgment will trigger the PCP to have a discussion with the patient about their mental health and to introduce the collaborative care model to include payment structure. If possible, a warm handoff will occur to provide a face with a name and possibly a chance for the patient to hear from the behavioral health specialist directly what treatment would look like. The PCP will then generate a referral that will be routed to a referral coordinator. The referral coordinator processes the referral and authorization with the patient's insurance company. They will then contact the patient to confirm they are interested in behavioral health services and will schedule an initial appointment with the behavioral health specialist. In addition to treatment strategies and a plan of care, medication management may be discussed at the initial appointment with the behavioral health specialist. If the patient would like to pursue medication as a part of their treatment, the behavioral health specialist will consult with a psychiatric consultant. Medication recommendations are documented by the psychiatric consultant and reviewed with the behavioral health specialist, and these are shared with the PCP. The behavioral health specialist will discuss medication recommendations and provide medication education in subsequent appointments with the patient. The patient will need to schedule and maintain appointments with the PCP for medication management. Follow-up appointments with the behavioral health specialist will be made with the patient at the end of each appointment. As the end of treatment draws near, the patient and behavioral health specialist will develop a relapse prevention plan and discuss what completing treatment really looks like, to include community resources, importance of continuing to communicate with their PCP, and how to return to services if necessary. Preparation and implementation. We'll start with COVID-19 and its effects on the process. The project was scheduled to begin in June 2020. A request was made to push that start date out to July as the pandemic response was at the forefront of healthcare and healthcare organizations. The pandemic response created delays in both internal and external processes, for example, credentialing of a new clinician and onboarding new contracted staff. Thankfully, our clinics were able to quickly adjust to the needs of their patients from the outset of the pandemic. Patients were given options for being seen both in clinic and virtually based on acuity of their presenting issues. Virtual or telehealth were implemented quickly to accommodate this and applied to both medical and behavioral health care. This is especially beneficial throughout the entirety of the pandemic and ongoing. There are some significant pieces to the implementation and preparation of this project specifically, but also to keep in mind when developing and implementing your own program. Quarterly programmatic goals and payment schedule were provided by HealthierHere. The meetings to review and discuss these were coordinated by Virginia Mason Franciscan Health to include Valley Cities and HealthierHere and the UW AIM Center. A point of note to mitigate challenges, very importantly, is if your organization will be contracting with another to provide collaborative care services, be mindful of your organization's practices for hiring non-employees, credentialing, onboarding, coordinating, and EHR access. Even without the delays by the pandemic, these processes can take a bit of time and can slow the process. If possible, have a person or persons identified that can help move you and the new behavioral health specialist through the process as smoothly and timely as possible. The big win that we had here was Valley Cities having a staff member, a licensed clinical social worker with the necessary credentials that was interested in the position. In light of current workforce shortages for behavioral health clinicians, the project was very fortunate in this regard. As soon as possible, invite the clinician to visit the clinic to meet the providers, the staff, and to see their physical space. If referrals are not being made, encourage them to begin. This will help the clinician's calendar to build and grow as quickly as possible and to get patients seen as soon as possible. If you have a workflow planned out, share with the clinic manager, operations manager, referral coordinators, and patient access representatives as soon as possible. Additionally, if you have a staff member familiar or easily comfortable with the process, utilize that resource. The more you can share with those that will be working the front end of the process, the better. Be certain the workflow works for your clinic, however. If trying to follow a one-size-fits-all program, challenges may arise. Keep all those participating in the process informed and up to date as much as possible. Hiring and credentialing can be a lengthy and time-consuming process. If at all possible, as mentioned, have a designated person or persons you can work with on this piece. An existing relationship between Virginia Mason Franciscan Health and the University of Washington AIM Center provided VMFH in having a strong knowledge of collaborative care, as well as how to bring it to the clinics in the most effective manner with the least amount of distress or disruption to the clinic. A crucial part of this is providing the clinicians with as many tools as are available and to do so with the most amount of lead time possible. In addition to online learning, UW AIM Center provided one-on-one training virtually and made this opportunity available for months to follow once the clinician began seeing patients. Training and support are available outside of the new user training and is available ongoing. Success of the new services of the Des Moines Clinic came through support and coaching. Support for the behavioral health specialist was organized prior to them beginning in the clinic. We're very fortunate to have a seasoned veteran behavioral health specialist that has practiced collaborative care since its inception at VMFH. This behavioral health specialist has been invaluable to the program in many ways, including support for the new behavioral health specialists prior to them being in the clinic, providing the opportunity for the new clinician to shadow, individual weekly calls, availability for questions at any time, support, and feedback. All of the behavioral health specialists meet monthly for peer consultation as well. Also, the behavioral health specialist meets with the psychiatric consultant on a weekly basis. Being part of the team in the clinic, the behavioral health specialist attends the monthly staff meetings. They also maintain communication and support from a manager with Valley Cities. Support from the University of Washington AIM Center was provided prior to being in clinic and continued for several months thereafter, and as previously stated, is available as needed. Upon starting at the clinic, the clinician had elbow support from our EPIC support team, and that was done for the first 2 to 3 days of patient-facing care. This person assisted the clinician in establishing their preferred template for documentation and EHR use. They were able to sit in on appointments with the clinician and their patient, with patient approval, of course, and this helped to organize their template and their documentation. Let's take a look at some of the wins in this part of the process. Preparation and implementation. Relationships. They are likely the most significant part of the success of your program. This project benefited from having strong relationships with all stakeholders, having enthusiastic champions, leadership, physicians, behavioral health specialists, as well as having a robust existing collaborative care model. Some EHRs have a tracker or registry or method to track patients' progress, however, others do not. The version of Epic currently in use at VMFH does not include an application to track patient progress in behavioral health care. The capacity to build such a tool is not available at this time. However, VMFH was able to contract with the University of Washington Ames Center for purchase of their caseload tracker. Virginia Mason Franciscan Health chose to purchase the caseload tracker for a number of reasons. The first being that the tracker provides valuable quality metrics. The data captured is easy to interpret and share with clinicians and leadership. The UW Ames Center provides thorough training prior to implementation of the tracker in the live environment, as well as ongoing training and support. Security, a must. Related to security, the tracker information is in a secure cloud held by University of Washington Ames Center. PHI is secure. Utilization of the tracker enables clinicians to capture the time spent with patients, providing outreach and collaboration, which makes for succinct capturing of information for end-of-the-month billing. Updates to the caseload tracker occur frequently with the information, instruction, and links provided for the behavioral health specialists. The ability to reflect on the work that is being done is imperative. Quality metrics are always important. Utilizing the Ames caseload tracker, entering it into a monthly spreadsheet, as well as internal data that is available to the clinicians through the HR, have helped to provide evidence of the progress made with patients enrolled in collaborative care services. The Ames caseload tracker provides data to complete a monthly caseload spreadsheet that was shared by the Ames Center. Once that information is compiled and put into the spreadsheet, it is shared with the clinicians as well as leadership. So here's a look at the caseload tracker. The Ames caseload tracker was implemented by all of the clinicians following training provided by the Ames Center. Training for the new behavioral health specialists began prior to starting in the clinic. An account was set up by the account administrator, for the clinician in the practice environment before having an active account once patients were seen. Ongoing support was provided by the Ames Center. The Ames Center provides routine upgrades to the caseload tracker. These updates enable the tracker to provide further caseload statistics. The tracker is incredibly useful with collaborative care billing, which we will get to shortly. More recent additions to the tracker are average session duration in minutes, average number of phone video time, average weeks in treatment, number of charts flagged for review. These all help give a much clearer picture of the patient's care. Additional information on the Ames caseload tracker is available by accessing the link here. This is an example of the monthly caseload spreadsheet that is used to consolidate data that is extracted from the caseload tracker. The spreadsheet was provided by the University of Washington Ames Center. A look at wins in relation to quality metrics. Some tips for success utilizing the metrics. Use solid tools for measurement. If you're working with the University of Washington Ames Center and have access to the tracker, I recommend using it for not only monitoring monthly data, but to encourage clinicians to review their caseloads, to evaluate monthly check-ins, moving clients to relapse prevention, or discharging them from service. If you have access to the University of Washington Ames Center, discuss using the monthly caseload spreadsheet. Share the monthly data with your clinicians. Share the monthly data with leadership as well. This provides capacity for clinicians and clinics and is useful in evaluating staffing, revenue, and sustainability. Let's turn to collaborative care billing. Virginia Mason Franciscan Health is very fortunate to have a coding and billing department that was on board with the transition to the use of collaborative care billing codes early. This allowed the time and ability for them to connect with not only CMS, but with the University of Washington Ames Center and that helped drive the transition to collaborative care billing for Virginia Mason Franciscan Health. This is also an area to pay attention to in developing and implementing the collaborative care model. It will benefit your clinicians and organization immensely to have a point of contact. Virginia Mason Franciscan Health is also very fortunate to have such a person available. Our coding specialist is well versed in the coding process for collaborative care and provides annual training to providers and the behavioral health specialist, as well as anyone else who needs training or support. A look at the collaborative care billing codes. They are different from psychotherapy codes, clearly, and they are laid out here and more in depth using the links on the following slide. Several links, some to the University of Washington AIM Center, another to CMS. This is a look at the collaborative care billing workflow, courtesy of the UW AIM Center. It was a great benefit in setting up our sound workflow. Primary care providers will be obtaining PHQ-9 and GAD-7 scores for their patients that will drive the discussion of and potential for referral to engaging in collaborative care services. It is essential that the provider include documentation of a consent statement. The above statement is from the APA. However, your providers may develop their own statement and/or smart phrase. But the bottom line is a statement must be included in their documentation. A link to the APA is on our next slide. VMFH utilizes Epic as its EHR, as mentioned. Recognizing that every system may be different, these steps may or may not apply to your organization. This will, however, give you an idea of what billing for collaborative care looks like. For the behavioral health specialist, to start the process, they will select a level of service. In our record, it's BHCOCM, Behavioral Health Collaborative Care Management. Second step is to begin a new encounter and then identify the patient. They will then select a new encounter, type of encounter, and the PCP. Add a visit diagnosis and reason for call. Behavioral health can simply be used as the reason here. The clinician will then create a note. Please take note of the example of a monthly billing statement here and all that those must include. The next step is use of the collaborative care management note template. It includes time and associated month as seen in the previous example. They will then check the cosign required and include the patient's primary care provider. Each clinician may have their own statement for end of the month billing, but key to the statement is that the note include number of minutes spent providing collaborative care for the specific month. Step 9, under wrap up, they choose the appropriate billing code BHCM section. So that would be utilizing those billing codes. Next, the clinician will select and change billing provider to patient's PCP and service provider to behavioral health specialist. Additional diagnoses can be added here if needed. The note is then submitted. Encounters are reviewed by the coding team for required elements of billing, and after their review, they are released to the payer. If corrections are required, it will be sent back to the behavioral health specialist for review and correction. At Virginia Mason Franciscan Health, reimbursement is split between the behavioral health specialist, 75%, the primary care provider, 20%, and the psychiatric consultant, 5%. Productivity and revenue will look much different from medical model billing. This is important to remember when productivity is reviewed and analyzed. Some of the wins we've had in relation to collaborative care billing. If at all possible, if you can have one behavioral health specialist that's able to become well-versed in the process of initiating and practicing collaborative care management to your practice or organization, it's an enormous benefit. This person can work with the AIM Center, billing and coding team, and providers to build a framework will be used to train and offer support to other behavioral health specialists. Importantly, have a plan and process in place to build the model. Try to front load the process with knowledge, training, and support for all of the clinicians. Also, utilize tools and services that are available for support wherever it is needed. The financial modeling workbook provided through the AIMS Center provides a thorough look at the cost of a collaborative care program using both traditional psychotherapy codes as well as collaborative care billing codes. I recommend highly that you click the link here to take a look at the modeling workbook. Setting yourself up to succeed. Very, very important piece here. To set your organization up to succeed, engage the supports and resources that are available to prepare, to educate, and train your staff and clinicians. The coding and billing department was very fortunate to have a person designated to learning collaborative care management and working with UW AIMS Center to ensure the knowledge and information was at the forefront of this migration to coding and billing. This allowed for the lead clinician that we have here to work with them individually to navigate and troubleshoot along the way. The use of the financial modeling workbook is beneficial. I will wrap up here touching on the sustainability of implementing collaborative care in the primary care setting and how Virginia Mason Franciscan Health is moving forward in this work. The revenue that's been experienced by VMFH has been encouraging and is supporting the ongoing use of the billing codes. Ongoing communication and work with the coding and billing departments to address changes and or issues related to collaborative care billing or reimbursements has been essential. Again, having the resource and relationship with the department will go a long way. Although the contract with Valley Cities covered by the Innovation Fund has expired, Virginia Mason Franciscan Health and Valley Cities entered into a separate agreement to continue to provide in-person behavioral health services at the clinic site the Innovation Fund helped build. Utilizing the data available with the caseload tracker as well as internal methods of extracting data are used to support the use of the collaborative care model. As the UW AIMS Center and HealthierHere have been exceptional partners in the implementation and ongoing practice of collaborative care, continuing to use their knowledge, resources, and services for support has been essential and is very much appreciated. Finally, through the success of the practice of collaborative care in the Des Moines Clinic, providers will be encouraged to continue to make referrals for their patients to participate in their overall health care by tending to their mental and behavioral health with a strong team approach. I would like to thank HealthierHere for the opportunity to participate in the Innovation Fund testing models for integrated care, Valley Cities Behavioral Health for being a fantastic partner, and of course, the University of Washington AIMS Center. Should you have any questions related to the implementation of collaborative care in the primary care setting, please feel free to email me at allison.conzora@vmfh.org. Again, thank you again and have a great day.